Well, thank you all for coming today. I think Nick and I had planned this meeting to be somewhat interactive, but I think given the size of the group in the High Plains, we'll probably hold all the questions to the end. And so what I'll probably do is kind of go through a series of cases that are interesting for you guys to contemplate. I'll pause, but then I'll sort of give you the answer. If you guys have a moment to sort of jot down questions as we go along, and then at the end of the presentation, we should have plenty of time to open the things up for questions and discussion. So does that sound okay? All right. So today's lecture will be basically a case-based evaluation of high blood pressure, cholesterol, and diabetes. And we'll start with my credentials. I'm a physician over here at CPC. I've been here for about 15 years. I've been a cardiologist for about the same time, and I work over at a federally qualified health center for a safety net hospital called Denver Health in downtown Denver. Page down. I lost my webcam. Is that bad? You're still there. You guys can still see me? Okay. So today's learning objectives will be first to focus on antiplatelet therapy, and those are blood thinning medicines like aspirin and Plavix, and how we apply those to primary and secondary prevention. Next, we'll talk about cholesterol therapy, and then high blood pressure cases, specifically focusing on some of the new guidelines there. And then finally, we've added a new module this year, which is looking at diabetes medications and trying to understand how they can reduce the risk of both micro and macrovascular complications. There's actually differences amongst the meds. And I think one of the areas that, at least for the providers sitting in the front row, that we really want to focus on is the challenges implementation of the new guidelines and how there's some conflicting data. So hopefully that'll be of interest to you guys. So this lecture will be somewhat similar to last year, but with some updates. So we'll focus first on aspirin, and we'll do lipids, followed by high blood pressure, and then diabetes. And then the next section will be the new guidelines, future directions, with a Q&A session. And in addition, we'd love to get your input from you and CC in terms of what things we can do to improve our program and how to improve the provider education that we're giving today, recognizing that this is the first time that I haven't driven up High Plains, and let me know if this is really suboptimal relative to Nick and I coming up in person. So let's start with our first case. I have a 45-year-old female. She lives in Lamar. She has no family history of heart disease, and she's here for a wellness exam. Her LDL, or bad cholesterol, is 191, and her total cholesterol is around 270. Question to you guys is, should she receive an aspirin every day to keep the doctor away? I paused for a moment, but in fact the answer is no. And the interesting point about this case is that even though the woman has very high cholesterol, because she's relatively young, and I think for those people in there, they're in their 40s, 40 is so young, her overall 10-year risk of having a heart attack or stroke is probably less than 2%. So aspirin prevention, as we'll talk about, probably is not that beneficial. Okay? The next question is now someone who's a little older, 49, this time a male. He has peripheral artery disease or blocked arteries in the legs, and he has pain when he walks in his legs, but no angina in the heart. Still smokes, blood pressure is normal, and LDL, or the bad cholesterol, is normal. And the question for you guys is, should this person, who is otherwise asymptomatic from a heart standpoint, still receive aspirin every day? And I didn't give an answer to this one, but I did say yes, and the reason is that he has established atherosclerosis, meaning that in contrast to the prior woman who hadn't had a blocked artery, this guy has a blocked artery, and so he probably should receive aspirin or maybe even clopidogrel for prevention. And what I wanted to show you next was a meta-analysis, a large study we did of over 100,000 patients looking at whether aspirin benefits people who have never had a heart attack or stroke in the past. And what you can see is this is what we call a forest plot, where anything to the left of the vertical line is considered beneficial, anything to the right is harmful, and at the very bottom you see that the ratio is 0.99 or almost 1.0, suggesting that even though aspirin for preventing heart attacks may be somewhat beneficial, it doesn't improve the risk of dying. And so it's not something that, at least in primary prevention, folks who haven't had heart attack or stroke, is definitely a powerful improvement in their health. So I think this is a really great, colorful slide. It reminds me a lot of the computer system called Oscar that we have, and this is the European Society guidelines as to when we should use aspirin for people that don't have heart disease. And what you can see clearly is that the first step is you've got to assess their global risk. This is something you can do on your iPhone. You can do this on a computer. You can do it on the Oscar system. But if they have a low risk or less than 10%, then you don't need to give aspirin. So that's red or stop. If they're medium risk, 10 to 20 in yellow, you can see that these patients can be prescribed aspirin, but that you want to go ahead with caution if they have any history of bleeding. And those patients, you might want to not go ahead and do it. Where it's a definite yes, where it's green, all systems go, is folks with a greater than 20% risk of a heart attack or stroke, even though they've never had a heart attack or stroke in the past. So that tells you the importance of quantifying risk. So let's shift now that we understand global risk. We'll talk about a 45-year-old female who presents for a wellness exam. Her LDL is very high. Her bad cholesterol is 191. Her good cholesterol is okay at 60. But when we use the ATP4 calculator to calculate her 10-year risk of a heart attack, it's still very low at only 1.2%. So the question to you guys is, even though she's very low risk, should she receive a statin or a cholesterol-lowering medicine to prevent heart disease? We'll take a moment. And indeed, yes. The answer here is that any adult patient who's able to drink in Colorado over the age of 21 but has an LDL cholesterol greater than 190 needs to be on a statin lifelong. And that's because this person has a genetic disease called familial hyperlipidemia where they run very high cholesterol. And even though their overall risk is low because they're young, they will in a lifetime be very likely to develop heart disease. Now let's shift to an older person, not that old, but 67, a female college professor, no history of heart disease, and wants advice on the new guidelines. Her total cholesterol is 188. Her bad cholesterol is pretty good at 75. Good cholesterol is 60. She takes a diuretic or hydrochlorothiazide, HCTZ, and blood pressure is normal. She jogs and is a non-smoker. So what do you think? Using this data, would you think this person should be on a cholesterol pill? And the hint would be using your TouchTone mobile phone app that you can download, the atherosclerotic cardiovascular disease risk factor, calculate her 10-year risk. And the answer is actually surprising. It's yes, that despite her having a normal cholesterol, because her 10-year chance of a heart attack is 7.5, which we now use as the cutoff for deciding whether people should be on a statin, she in fact should take a moderate or high-intensity statin. So it's a little controversial, but something to be aware of for the guidelines. Now let's move to a patient who's young, 49, type 1 diabetic, long-standing for the past 15 years, is on insulin and lisinopril. The LDL cholesterol is decent at 88, the HDL is 60, blood pressure is normal, doesn't smoke. Now we use the ATP4 calculator, and the 10-year risk is again low at only 4.4% and no heart disease in the past. So the question is, should this diabetic receive a statin to prevent cardiovascular disease? And as you know, most of my questions are somewhat tricky and controversial, but I will take a moment to let you answer that. And in fact, yes. The key to this question for your boards or for your certification exam is that because the person has diabetes, so long as their LDL or bad cholesterol is over 70 and they're an adult, they should receive a lifelong statin, irrespective of the fact that their LDL is controlled. And this is a diversion from guidelines a couple years ago where we used to target less than 100. And so now even a person with an 88 on their bad cholesterol, if they have diabetes, should be treated. Now the next case is we're going to move to someone who actually has established atherosclerosis, who had an angioplasty and stent put in the LAD artery in 2008. The patient is doing very well from lifestyle perspective. His LDL is super low at 63. HDL is good. Blood pressure is normal. He doesn't smoke cigarettes. He takes an aspirin a day. And the question is, based on the new ATP4 guidelines, what should the patient receive? A very high dose statin at 80 milligrams a day. B, no treatment is warranted. Or C, a lower dose statin called Pravachol, 40 milligrams a day. Surprisingly, the answer based on the new guidelines is this person would be put on a very high dose high-potency statin because the patient has established disease. And the adage is, irrespective of their LDL, you want to really treat that cholesterol aggressively. I think certainly all of us could make a good argument in this case to use treatment C and go with Pravachol and drive the LDL cholesterol into the 50s, but not have to drive it down further. But that's a good question for us to contemplate. Now we'll talk about an even higher risk person, someone who has had what we call an acute coronary syndrome. This is a 70-year-old man who smokes and came in with a small heart attack or angina and got a stent to his right coronary artery a month ago. He is asymptomatic and is receiving aspirin, beta blocker, ACE inhibitor, Plavix, and a very high-dose statin, rosuvastatin, 40 milligrams a day. Blood pressure is 130/80. Triglycerides are a little bit elevated at 250, and the LDL is 71 milligrams per DL. So your choices are, do we increase his Crestor to 80 milligrams? Do we add ezetimibe or Zetia 10 milligrams per day to lower the LDL further? Or do nothing? He's already on a statin. Or do we add amlodipine, a blood pressure pill, to target his blood pressure to less than 120/80 millimeters of mercury? The drum roll, please. The answer, at least based on the ATP4 guidelines, is to do nothing. He's already on a statin and a high dose at that, and so we wouldn't do anything. However, I do want to raise the issue that there is some additional data suggesting that maybe we want to drive the LDL down a little bit further. This is a study of 18,000 patients who had heart attack and found that if you went ahead and got the LDL cholesterol to go from 70 to 53 milligrams per deciliter with ezetimibe, that indeed people would do somewhat better, that you would slightly reduce the rate of heart attack, death, or stroke. And so this actually supports the older guideline where we say treat the target and go to a LDL cholesterol less than 70 milligrams in those patients who have suffered an acute coronary syndrome. And this was just published last year in the New England Journal of Medicine. All right, so let's summarize what we've learned today, particularly about cholesterol. Bottom line is that we're moving towards a risk-based category, and there are categories. If you have to remember anything, this is the thing to remember. If people have familial hyperlipidemia or they have a genetic problem where they have very high cholesterol, greater than 190, always recommend lifelong high-intensity statin. In addition, if the patient has diabetes and their LDL is in that range of 70 to 189, they should get a statin. And in particular, if their risk of heart attack or death is over 7.5% per 10 years. Finally, the obvious one is if they have known cardiovascular disease, either in the heart, in the legs, or in the neck related to a stroke, they should get a high-intensity statin irrespective of their LDL level, regardless. And finally, as I alluded to earlier, those patients who haven't had heart attacks but have a moderate 10-year risk score greater than 7.5 and an LDL between 70 and 189, they should all receive moderate or high-intensity statin based on the new guidelines. Well, what is the definition of a high-intensity statin? Just so you guys are clear, at least in the United States, the main drugs we're thinking about are Lipitor, which is now generic as atorvastatin, and Crestor or rosuvastatin, which will be generic shortly. And you can see to the right column the moderate intensity statins that you can use for those patients that don't have established heart disease. So what are the advantages of the new guideline? I think it's sort of the Clint Eastwood movie, if you will, the good, the bad, and the ugly. I think from my perspective, the good, that it's emphasizing statins rather than non-evidence-based medicines like fibrates or niacin, and even the omega-3 fish oils. In fact, the FDA has removed the label indication for fibrates and niacin other than those with very, very high triglycerides, over 500. Another advantage, I think, is the simplicity of the 4 groups. So we're doing more of a public health or a population-based approach, which I think all of you guys are doing in High Plains, where you're looking at panels of patients and trying to manage those panels to optimal risk factors. So I think that's useful. And I think although there is no data for pre-specified treatment targets per se, I think it's nice to sort of just focus not so much on the number all the time, but just getting the population on the drug. I think the bad side of it is that we're probably over-treating some of the low-risk patients now that we went from 10% to 7.5%, and those may already have an LDL below 100, and so it's not as clear that these people will benefit. Flip side is there's potential under-treatment of people that still have a high LDL. Because if we get rid of the treatment targets and we no longer try to get their LDL below 70, I think some folks are actually going to lose benefit. And I think the only ugly one is that the risk calculator for statistical purposes was only based on African American and white patients and doesn't deal with Latino populations, which I believe is a big population here in Denver, and certainly out in Lamar, the Latino population is increasing substantially. So let's toggle now. We've talked a lot about lipids. Hopefully you guys can remember some of the categories and some of the stuff we talked about. And now we'll talk about high blood pressure, a 61-year-old African-American female who is very healthy, but is concerned about a very concerning family history where both her older brother had a stroke with high blood pressure, a mom, a heart failure, a dad, kidney failure. She's currently on cholesterol pill and aspirin, but her blood pressure is still elevated at 149/87. Her BMI is normal, her kidney function is preserved, and her LDL cholesterol at 130 is only slightly elevated. So in terms of her blood pressure of 149/87, my question to you guys is, which of the following would you recommend? Would you start a low-dose diuretic or hydrochlorothiazide to get the blood pressure to less than 140? Do you just reassure her and tell her she's doing well? Do you start a calcium blocker, another type of blood pressure pill, and shoot for a blood pressure target of less than 130? Or irrespective of blood pressure, do you start an ACE inhibitor to protect the heart and the kidneys regardless? So I'll give you a moment to think about this case and what to do with her blood pressure of 149. Actually, if you look at the JNC 8 guidelines, they suggest that no therapy is needed, and the reason is that patients that are considered 60 years old or over are considered really old. I'm not liking that now that I'm about to turn 51, because that means I'll be considered really old, and no one will want to treat my blood pressure to the normal goal of less than 140, and they'll only go for less than 150. So I think in that sense, many of us would actually go with either choice 1, choice 3, or choice 4, but I wanted you to be aware of the controversy with some of the newer guidelines. Let's move to another case. This is a 51-year-old man, so my age, but has diabetes, hypertension, has had open heart surgery, has kidney failure and heart failure. He's on a beta blocker, a cholesterol pill, aspirin, and an ACE inhibitor, another type of blood pressure pill, as well as a diabetes medicine. Blood pressure is 139 systolic. His kidney function is elevated at 2. Glucose is well controlled at 118, and his LDL cholesterol is only slightly above optimal at 118. And so the question primarily regarding hypertension is, which of the following would you recommend? Would you, 1, start a calcium blocker and target a blood pressure less than 130? Do you simply reassure him and tell him that he's doing well? Number 3, do you start a calcium blocker and shoot for 125/75? Or do you switch from Lipitor to Crestor, a stronger cholesterol pill, and try to get his LDL below 100? And finally, your choice of both 1 and number 4, handling both his blood pressure and his cholesterol at once. So I realize this is somewhat of a complicated question, but it has a number of teaching points embedded. In fact, the answer is no therapy for JNC 8, because again, they recommend that as long as you're less than 140/90, you're essentially good to go. A lot of us, however, would really shoot for either target 1, 130/80, or target 2, 125/75, and that's because the chronic kidney disease may actually do better with a lower blood pressure. So I wanted you to get a handle on that. In addition, many of us would also try to get his cholesterol lower still, since he's already had a bypass surgery. So what are the implications of the new JNC 8 guideline? The problem is that if adopted, this would lead to undertreatment of 6 million Americans, and that's primarily due to the relaxed blood pressure target in those old fogies over the age of 60, which we used to not think was very old. The authors extrapolate that a number needed to treat among patients over 60 of only 10 individuals to prevent a CVD death. And so our concern is that although there has been a decrease in the risk of stroke and heart attack in the United States, if JNC 8 was implemented, this would be very harmful, particularly to those who are over the age of 60 years. So we at the Colorado Prevention Center and part of our program don't really believe in adopting this guideline. In fact, myself and a number of other doctors here at the CPC wrote an article asking the question, is 60 the new 80 in hypertension? Kind of making fun, if you will. And the reason we're sort of questioning that is there's a new study called SPRINT, which is actually suggesting a lower blood pressure goal. This was a big study, the largest that we've seen, of almost 10,000 patients, and they were randomized to either a goal of 120 or less than 130 for their blood pressure. Patients were older, so as you can see, 68, so older than the JNC 8 guidelines saying that 60 is really old. And the difference in blood pressure was 14 millimeters of mercury. And actually, the study was stopped prematurely after only 3 years, and that's because there was a 25% lower chance of having a heart attack and a reduction in all-cause mortality of 27%. And interestingly, this benefit was seen even in patients over the age of 80. Now, I will make a caveat that in this study, when you treat blood pressure to that low of a level of 120, you're going to have more hypotension, you're going to have more fainting spells, you're going to have changes in electrolytes, some kidney failure, but no injurious falls. So there is a price to be paid, but the benefit, of course, was that you have less people dying and less people having a heart attack or a stroke. So we'll pause for a moment, and now what we'd like to do is shift. We've talked about cholesterol, we've talked about blood pressure, and now I want to talk a little bit about glycemic or blood sugar control in our patients with diabetes. We'll start with a 64-year-old male with type 2 diabetes mellitus, and he presents to the High Plains Clinic for control of his blood sugar, which has been running in the 200s. His hemoglobin A1C is 8.7, and he's read online that he should be closer to 6 or 7. He does take insulin, metformin, a cholesterol pill, and an aspirin. His systolic blood pressure is at goal at 130, but he's actually worried about developing heart disease because his Uncle Tommy had had a bypass surgery at the age of 65, and that's coming up on his birthday in about 3 months. So he asks you, since you're wanting to start him on an additional sugar controlling medicine, what should he choose? Which one would be most likely to reduce his risk of having a heart attack or a stroke? Is it 1, pioglitazone, a thiazolidinedione? Is it 2, glyburide, a sulfonylurea? Is it 3, liraglutide, an injection that's a glucagon-like peptide 1 analog? Is it 4, acarbose, which is an alpha-glucosidase inhibitor that prevents the absorption of sugar? Or is it a DPP4 inhibitor named saxagliptin? So I'll just take a moment to let you guys contemplate. And the answer is actually liraglutide, a newer drug, which is a GLP-1 analog. Let me share some of the data regarding the study of this medication. The study was called LEADER. It enrolled 9,000 diabetics with type 2 to either a placebo or liraglutide, and found that heart disease events such as a heart attack and stroke were reduced by 13%, and death rates were reduced by 15%. There were, however, adverse effects, particularly gastrointestinal side effects from the medication. I wanted to share that with you. Let's do another case. This time it's a 59-year-old type 2 diabetic, and she's an insurance manager for Cigna. Her A1C is 8.2. She takes insulin and metformin and has mild proteinuria, which means that there is protein products going out in her urine, which is a suggestion of early kidney damage. And she wants to improve her kidney damage and her heart disease risk and prevent going on to dialysis. So she wants to get her sugar better, and she asks you which of the following 5 medicines she should look at. Is it 1, rosiglitazone, another TZD, glipizide, a sulfonylurea, empagliflozin, a sodium glucose cotransporter inhibitor, again, acarbose, or saxagliptin? And drum roll, the answer is actually the newer medicine, empagliflozin, which is a sodium glucose cotransport inhibitor, which actually allows you to pee out more of your blood sugar in the urine. And let's talk about this study. This was a trial of empagliflozin, 7,000 patients that got drug or placebo, and the results were that the cardiovascular events were reduced by 14%, which was driven largely by a 38% reduction in cardiovascular death. Now, in addition, the doubling of the kidney function or worsening kidney function occurred in 1.5% in the empagliflozin group and 2.6% with the placebo, which was a 44% reduction, albeit of a small number. And importantly, although the numbers were small, dialysis was developed in 0.3% of the empagliflozin group and over 0.6% with placebo, so again, a reduction. So I guess this drug at least appears to be protecting the heart and maybe somewhat protecting the kidney as well. So let me make some conclusions overall, and so we have plenty of time for the group to ask questions. It looks like we should be using aspirin in all of our patients that don't have a contraindication but have either established atherosclerosis or blocked arteries in their heart, legs, or in the brain, or those who don't have established atherosclerosis but have a 10-year probability of developing a heart attack or stroke that's greater than 20%. And our program, we can do this using our OSCAR system. The next important point that I would bring to your attention is that we really want to focus on aggressive cholesterol reduction in 4 main groups. Anyone with diabetes, anyone with very high cholesterol genetically, anyone who has blocked arteries, or as I mentioned, a 10-year risk that's greater than 7.5%. So just contrast that with aspirin. We're not as keen on starting unless they really have a very high risk of 20%, but we believe that with a statin, the cholesterol pills that have very low risk, for example, like bleeding, it is prudent to go ahead and initiate it. Now, in terms of blood pressure, I think that from our perspective, we really want to go back to the future and go to the older guidelines and recommend that a systolic blood pressure of less than 130 is probably the way to go in your high-risk patients. And at a minimum, at the High Plains Center, I would make sure that most of your patients have a blood pressure less than 140, so long as those patients are less than 80. Now, although the SPRINT trial did suggest that even 80-year-olds benefited from a blood pressure of 120, I'd be a little cautious about that, and again, I would be very comfortable with 140. When possible, and you're trying to control the blood sugar and the hemoglobin A1C, choose diabetes drugs that actually simultaneously lower the risk of cardiovascular disease events. And at present, it looks like we have 2 new drugs, a sodium glucose cotransporter and a glucagon-like peptide analog, that are the first 2 to show benefit. I think that's somewhat groundbreaking. Nonetheless, there's going to be issues of cost and insurance coverage, but be aware of those medications, and when possible, you might want to consider them when you haven't achieved your glycemic control targets. So let me give you a brief overview of our program, and then we'll open it up for questions. I think our program has been with you guys now for about 4 or 5 years, Nick, is that right? And we are calling it the Colorado Heart Healthy Solutions Program, and our goal was to really improve cardiovascular health across Colorado. And by the numbers, we've been very successful. We've been able to lower cholesterol, blood pressure, and even the global risk of having a heart attack or stroke by about 2.5%. And we've published this data in the American Journal of Public Health, and have been very fortunate to continue this with you guys, for which we're grateful. We have also shown that this program, by using a community health worker, and CC can comment on this, we've been able to really improve lifestyle changes as well. And this is a great resource both for people that are in the community, in Lamar and the surrounding areas, but also for your participants and patients already in care. We can go ahead and navigate them to our community health worker. So we need your input. If you have ideas about our program, whether it would be useful for your patients or clinic, whether you're even aware of our program, and if you need more information, we still have 20 minutes to discuss. And also, importantly, we want to know whether this type of clinical update was helpful, and whether or not you think this format, doing things by webinar, is useful, or if you prefer me to come out to Lamar, or if print or email type things would be better. Also, we want to know if you're getting our emails, which give you little case-based learning and some kind of snippets of information in terms of newer information. So I think with that, I'm going to leave it at this. I need CC to bring the microphone around and give us some comments.
Hi, I'm Susanna Storing, one of the PAs here. I'm very happy that you were able to do this. It does give us a lot of information. I think that the webinar is a fine way to proceed. We do have a question about the one case study that you presented. There was a, I believe it was a 51-year-old diabetic with hypertension, and yes, so diabetic and hypertensive, and the blood pressure is not to that quote-unquote target. But from the looks of it, you know, my thought would be that we would go with both getting a target blood pressure less than 130/80, as well as getting that LDL to less than 100 just because of that risk factor of the diabetes. Where am I wrong in the thinking there?
No, in fact, if you were my primary care physician, I would be really happy. That was me because I'm 51. Luckily, I don't have diabetes and a bypass surgery. But can everybody see the case on the screen? Can you guys see it? Is
Yes,
it
thank you.
Yeah, so I'm completely in agreement. And again, part of the purpose for me presenting is to show you guys the controversy, not just tell you what to do, but let you know what some of the guidelines say. And so just because, as I scroll down, the answer is that the patient, according to JNC8, should do nothing and get reassurance, and based on ATP4, their cholesterol is fine, you should do nothing, they're already on a statin, that is completely correct. And in fact, this is a high-risk patient, and this patient has kidney disease, and all of us would recommend that we go back to the 1990s or 2000 and say, hey, I know it's 2016, but sometimes it's an oldie but a goodie. This person should be less than 130/80, so I would definitely probably initiate a little bit of Norvasc or amlodipine in this patient, get him to about 130 or 129 on its systolic to protect his kidneys and prevent him from going on to hemodialysis. In addition, I would by all means switch him from Lipitor to Crestor because, as we know from the studies, diabetics and people with coronary disease that are high risk will benefit from an LDL cholesterol at least less than 70 and maybe an LDL cholesterol in the mid to high 50s. So I completely agree, and you are not missing anything.
Thank you very much.
Doctor. Yeah, yeah.
I'm a good PA. Thank you.
Yeah, there you go.
Oh, yeah. The other question that we would like to pose is if you could send the PowerPoint to CC, and then CC can send it on to all of the providers. We're also interested in knowing the study, the particulars of the study that for both the SGLT1s as well as the SGLT2s and the DPP4s that help with the cardiovascular prevention in those diabetics, because we will need those for getting prior auths. If we're faced with prior auths, if we can send the study to those insurance companies, oftentimes we will be able to get those with less of a struggle.
Yeah, and I think what I'll do is, as you can see, I've only sort of casually referenced the New England Journal of Medicine article, but what Nick can do is send you PDF copies of the actual New England Journal papers, because both of these articles, both for the liraglutide, as you mentioned, as well as the empagliflozin, the sodium glucose cotransporter, were published in the New England Journal of Medicine. So I think that's what we'll do is when we get off this conference call, we'll send those to you. And again,
Great.
I want to make sure you're clear that I'm not, this is a non-promotional talk. This lecture is funded solely by the state, so I'm not recommending any specific drug. I think metformin certainly is my first go-to, but the reality is most of your patients aren't going to get to target with just metformin and maybe not even with a long-acting insulin. So I do think that, the data is the data, and you guys can parse through it, but this is a big change in 2015 and 2016 to finally have diabetes drugs for type 2 or that are oral or injection that are actually shown to improve cardiac and kidney risk. So it's a bit of an exciting time, and what to do with it and the cost is certainly complicated. At the same time, as providers, we're first and foremost trying to help folks. And so I'm glad to hear that you're interested in these, and we'll get them to you right away.
Thank you very much.
Hello, my name is Josh Norman. I'm also a PA here. What's that app for the ATP4? Because I've been trying to find it on my phone, and I have a couple of apps, but I can't find that one that's going to actually have me calculate that actual risk factor.
So if you go to your app store, if you guys can all just type in A as in apple, S as in Sam, C as in cat, V as in Venus, D as in dog, the atherosclerosis cardiovascular disease risk estimator, so ASCVD risk estimator, it'll pop up. and that's basically the new ATP4 guideline that was done by one of the board members for our organization, Colorado Prevention Center, Dave Goff. He's a preeminent internationally known cardiac epidemiologist, and so he came up with that, and that's really the best one that we should be using. So again, if you just go to App Store and then type in ASCVD, Risk Estimator, you should come up and it's a free download. And it only takes about 15 seconds per patient to get your risk score.
Okay. Thank you very much.
Okay. You're welcome. Thank you for the question, Josh.
The emails that you send to CC, how often is that you send them to her?
So the emails shouldn't be really going to CC. They should be going to all of you. So I'd be curious to hear if Josh and others in the group are receiving my emails, and they come out monthly. If they're not receiving it, then I think we really need to figure out what's the glitch in the system, because that's part of our deliverable to the state health department, is to make sure that you're getting monthly education. And it's important from our perspective because it's something that is valid and legitimate, because it's not, biased by, a third-party payer. And one thing
But none of us are, sorry, none of us are getting the emails.
Okay. So if you guys collect emails and you want to receive these monthly, we call them provider detailing emails, you can send them to us and we'll just add them to our distribution list.
Okay, we will do that then.
But I guess my question to you is, I've been coming to High Plains for a number of years, so are some of the physicians or PAs that have been there for a few years, at least, are they getting them? Do you know? Like the first two that, or are they new?
The few that have been here for a while are not getting any of them, no.
Okay, so I think luckily Nick has been working to enhance the system. I think we've had a really antiquated system that doesn't work very well, that's not dynamic and updating, but we're going to really put an effort this year in terms of making it happen, because I think, we really want you guys to feel connected to us and our program, and we love it if you get an email or a detail, and even if you say like, well, I don't agree with this, and shoot me an email back, that interaction is tremendously satisfying for us, and hopefully is a prelude to more knowledge. So we apologize, but if you could get us a list of names and emails, that would be so helpful.
And this is Nick Flattery, and I'm the Senior Project Manager for the Colorado Heart Healthy Solutions Program. And I just want to give out a big kudos to Beth Parker, who's we fund her position in part. She's our health coach, I think is what you guys refer to her as, but she's just done a fantastic job, her and CC, to help incorporate, the evidence-based portions of this program into what you guys already do, which is very fantastic. So I just wanted to give big kudos to those two. Are there any other final questions?
One more question before we finish. You mentioned the study of the diabetics and the use of anti-diabetic meds that save renal function. I was wondering if, of course, this is a big extrapolation, but if there were people with other type of kidney disease, not necessarily diabetic renal disease, would you still choose? I guess probably don't have data, but maybe you have an opinion whether you would choose the meds that save renal function, even if the renal disease is non-diabetic.
Yeah, I think it's a great question. I think when you look at the two major causes of kidney failure in the world, it's hypertension, and diabetes is a close second, or sometimes it's the opposite. But if it's purely hypertensive renal disease, although there's some suggestion that empagliflozin may have beneficial effects at the glomerulus, it's not something that we would ever want to initiate in someone with pure hypertension without diabetes. So your question is really good. in those patients, what we recommend is very high dose ACE inhibitor drugs. So if you're using lisinopril, you would try to target a dose of 40 milligrams. Or if you're using, let's say, an ARB like irbesartan, you would shoot for 300 milligrams. Or, if it was losartan, you'd shoot for at least 100 milligrams. So the idea is that the primary mechanism of protecting the kidneys in folks with a creatinine of 1.5 to 2.1 is to get them on very high dose ACE or ARB if it's purely hypertensive. You would do the same thing with the ACE and ARB for the diabetic patient. The only difference would be you would, again, emphasize glycemic control to an A1C level in the mid-6s or about 7, and that you might consider some of these other drugs that seem to have kidney protection. Does that make sense?
Yes. Just a follow-up. So with diabetic renal disease, early on you mostly rely on albuminuria, so you kind of measure that and use that as a guideline on whether to start certain antihypertensives. Would you follow the same parameter? Would you look at microalbuminuria as a tool to make a decision on choosing antihypertensive or other meds in those patients that are diabetics with non-diabetic renal disease?
Yeah, and I think you're raising a really important point. We published a study of microalbuminuria in a study that we followed for, I think, 10 years, the appropriate blood pressure control and diabetes that we initially published in New England Journal and subsequently published in the American Journal of Cardiology. What we found was the biggest predictor of cardiovascular death was proteinuria, and the change in proteinuria was protective. And so I think in all of our patients with diabetes and hypertension, one of the things you should always measure is a ratio of urine to serum albumin, and that ratio, if it suggests proteinuria or microalbuminuria, should always be a cue to be more aggressive with considering medications like the ACE inhibitors or the ARBs. And you can have proteinuria both in diabetic and non-diabetic renal disease, but the key point, though, is that probably independent of whether or not you're proteinuric renal disease, if you have renal disease, period, by whatever mechanism, which hypertension or diabetes are still going to be the predominant reason, those are people that meticulous blood pressure control to less than 130/80 is going to be your primary goal, followed by choosing ACE inhibitors or ARBs, followed by, if indicated, considering one of the more protective diabetes medicines. But in addition, lowering cholesterol and other risk factors may also have small benefits. So I think hierarchically, the way I would approach it is that any kidney disease, blood pressure control is first and foremost, and then choosing the ACE or the ARB. But using that proteinuria screen that you had mentioned as a way to really push you over the edge to sort of initiate a blood pressure pill, even say someone who's got a blood pressure of only 131, that's borderline. But I think if they've got proteinuria, that answers the question. ACE is the place.
Thank you.
Yeah, thank you. Great question.
I don't think we have any other questions today.
Okay, great. Yeah, we'll try to get you guys the PowerPoint, those articles as well. And then we are going to post this webinar on YouTube. So we need to kind of edit everything, down, and then we'll send you a link to that as well. But we want to thank Cece especially for helping to arrange this and get everybody there. So thank you, Cece. And if you have any final questions, you can get those emails to us as well, and those names, and we'll put those on the list as well.
Yeah, thank you guys so much. I really appreciate your attention, and we're so glad to be able to partner with you guys. So I look forward to our next visit in person, or if you guys are interested in another lecture, we're always happy. Thank you.
Thanks so much. Nick, we were wondering if you have other videos on YouTube as well.
I'm sorry, could you repeat that?
Do you have other videos on YouTube as well?